When it comes to the electrical activity of the heart, everything comes back to how those muscle cells of the heart have those intercalated discs and how they're able to conduct electricity, conduct depolarizations from cell to cell to cell to cell, right? So we get direct cell-to-cell communication saying, hey, dude, you need to contract. Hey, dude, you need to contract. Hey, dude, got you, right? Like that is the entire basis for the electrical activity of the heart. So what generally happens and what tends to happen in a normal physiological heart is that we have a set of specialized cells in the inside of the atria, inside of the right atria specifically, that are going to be called the sinoatrial node, or the SA node for short. You'll see me abbreviated SA node. You'll see the book abbreviated SA node, right? So the SA node, sinoatrial node. These are a set of cells with a very specific set of skills. Liam Neeson taken all day long, right? He's the dude. What can I say? So the SA node is largely going to be determined to be the pacemaker of the heart. As that electrical depolarization happens, right, as it hits, boom, boom, boom. Every single time that depolarization hits, we're going to have depolarization of the heart. There's a specific pathway through which that conduction or that electrical activity is going to actually flow, but in general, it's going to be that pacemaker. It's going to be that SA node firing that's going to cause the electrical depolarizations and eventual contraction of the heart to occur. So what is the electrical pathway of the heart? Well, it's going to start in the SA node. Those signals are going to travel across both atria, right? So it's going to send off across both atria. And it's going to travel south. So it's going to move towards the ventricles. If you remember, we talked that the ventricles have a special, there's a tissue separating the atria from the ventricles that don't conduct electricity. So that SA node has to make it over to something called the atrioventricular node. And that's a node that's another set of special cells, similar to the SA node, that sits between the atria and the ventricles. It's going to be the activation of this AV node that's going to control the depolarization and activation of the ventricles. So that activation and depolarization of the AV node is going to send electrical impulses down the left and right bundle branches. Those bundle branches are then going to kind of subdivide out into the Purkinje fibers. And it's that specific electrical pathway from the SA node to the AV node to the bundle branches, right and left, out through the Purkinje fibers, that's going to cause the heart to contract in the exact way that it does, which is atria contract, ventricles contract up and out. Atria contract, ventricles contract up and out, right? So that's what's going to give us that rhythmic squeezing motion in order to have the heart function as a pump. Because that electrical signal exists, and because it is literally electricity that is going to be conducting these signals and these depolarizations, we can actually read that with electrodes. So we can set electrodes on an individual, on a human, also on other types of animals, but humans are, of course, I'm saying it stupid on purpose. We can set these EKGs onto an individual, and we can actually read and interpret that electrical impulse. And the way that an EKG is set up is we set up with multiple leads and a ground wire. And the reason that we set up the electrodes in the specific manner in which we do, which you'll learn in exercise testing and prescription, is that it allows us to get a 360-degree view of the heart. So we can actually interpret the electrical signal all the way throughout the heart, so we can pinpoint things that are wrong with the heart based on the EKG. Kind of a cool topic, kind of a cool concept. So what does that cool concept actually look like in practice, right? So if you look at this graph, if you look at this chart, you'll see that we have a P wave right here. We have a QRS wave, and then we have a T wave. And what I want you to notice is that this P wave is atrial depolarization, right? So that is a fairly small bump. Remember, we only have to get about 30% of the blood from the atria and the ventricles. Boom, right? The QRS complex represents ventricular depolarization or ventricular contraction, right? So we have atria contraction, kind of small, and then we have a big ventricular contraction. This T wave over here is ventricular repolarization. So it's ventricular relaxation. It's the phase in which the ventricles are getting ready and filling with blood and getting ready to contract again. So that's exactly what's going on. So you have atrial depolarization and atrial contraction, ventricular depolarization and ventricular contraction, and you have ventricular repolarization. Something that's kind of interesting is that the atrial repolarization gets hidden within the QRS complex. Because it's occurring simultaneously with ventricular depolarization, we actually lose it almost completely. So you can't actually really visualize it on the PQRST complex waves. And if it's going to be an EKG, all that this would look like differently compared to this wave is you would have a whole bunch of these waveforms on a long sheet of paper, and it would basically be reading exactly what's going on with the heart. So you would have 12 different views. You'd have 12 different leads looking at every different angle of the heart. Sometimes you'll see this be inverted based on the way that the depolarization is traveling. If you guys want to talk more about that, we can talk more in the office. You can reach out and we can chat about it, however deep you want to go. But for this class, what I want you to know is this right here. So let's go and review everything that I just said, basically. So this P wave is representing the SA node depolarizing and causing an atrial contraction. As we get over, we're going to actually be seeing the QRS and ventricular depolarization or ventricular contraction occurring. And then as we get into the T wave, you can see that we're actually having ventricular repolarization reoccurring. So all that this figure is doing is showing you that the directionality of the depolarizations and the directionality of the repolarizations. I do want you guys to kind of notice here that the atrial depolarization actually spans all the way across the atria. It spans across both atria. It's able to jump the septum up here, but it's not able to jump the wall that blocks the atria from the ventricles. So how does that correspond to blood flow through the heart? Well, we have cardiac diastole, and we have systole, and we have diastole again, right? So let's think this through. What is diastole? Diastole is blood filling. So cardiac diastole, all chambers are relaxed and blood's flowing into the heart. In atrial systole, we're going to be pumping blood from the atria into the ventricles. In ventricular systole, we're going to be pumping blood out and up and through, right? P wave is what? It's atrial depolarization. So we're over here at B. QRS complex is what we're over here at C. And then that T wave, we're all the way back here, and we're back at this A figure again. Does that make sense? Good. Okay. Everything essentially that we've talked to up until 9, everything we've talked to up until now comes into play here with cardiac output. Cardiac output, or Q, is going to be the product of heart rate and stroke volume. So if we get a faster heart rate, we're going to get a greater cardiac output. If we get a bigger stroke volume, we're going to get a greater cardiac output. It's directly related. So the heart rate is directly related to cardiac output. The stroke volume is directly related to cardiac output. We can increase cardiac output by increasing either heart rate or stroke volume. If you look down at the bottom, if you look down at the figure, you can see that heart rate, or depolarization of the heart, or the contraction rate of the heart, is going to be driven by nerves and hormones. Nerves, we know that we have neural input to the heart via vagal tone, via the vagus nerve, as well as the accelerator nerves. You should remember that from anatomy. If you don't, shame on you. And then also hormones. What hormones do we know are going to increase our heart rate? Epinephrine and norepinephrine, right? Those hormones are making a comeback from last lecture to here. Stroke volume is going to be determined by blood volume and vascular resistance, right? Stroke volume is going to be determined by blood volume and vascular resistance. So how do we regulate the heart rate? Let's talk about one of those lines. Let's talk about just the heart rate. So Q equals HR times SV. We're focused on HR right now. Well, the SA node is going to be one of the primary regulators of heart rate. But what I want you to think about is that the SA node has an intrinsic rate of about 100 beats per minute. So if the SA node were to just fire on its own, it would fire at approximately 100 beats per minute. Most people, their resting heart rate is significantly less than 100 beats per minute. And that's because you have parasympathetic tone that's actually going to be playing a role here. You're actually going to have a parasympathetic innervation that's going to be slowing down your heart rate. It's going to actually be physically putting a small brake on your heart to slow down your heart rate, right? We're also going to have accelerator nerves that we can place on the heart in order to get the heart rate beating up faster and faster and faster than 100 to 110 beats per minute. And that's what you're seeing down there on the bottom. You're seeing that as we kind of decrease vagal tone, we're going to be increasing sympathetic tone. As we decrease vagal tone, as we decrease the parasympathetic innervation, we're going to be moving closer to that inherent automaticity, that 100 beats per minute that the S8 node would normally fire at. And as we back off on the vagal tone, we're going to be increasing the sympathetic tone, those accelerator nerves, and we're going to start getting that heart rate up and up and up and up and up. That's why when you're walking across campus in the middle of summer, it feels like you're working to high heaven, and your heart rate's probably like 140. At least if you're a fatty like me, your heart rate's probably about 140 walking up some of those hills. This is going to be where you start having sympathetic nervous system activity and sympathetic nerves playing in. Those nervous systems are going to function via norepinephrine, which are going to bind to the beta adrenergic receptors, and using very specific set of processing through second messenger system with cyclic AMP and G proteins, you're going to increase the heart rate as well as the contractile force of the heart rate. Heart rate variability growing these days, and the concept of heart rate variability growing, you guys have probably heard about this, at least in blogs or podcasts or whatever. If you haven't, I apologize. I just want to take a second to talk about it because it plays in with this parasympathetic sympathetic tone thing. Essentially, heart rate variability is measuring the variability between QRS beats, right? So Q was at the bottom, R was at the top, and S is at the bottom again, right? What it's doing is it's measuring the interval between R values on subsequent heartbeats. And essentially what it's saying is that as you become stressed or de-stressed, or as you increase sympathetic tone or increase parasympathetic tone, the variability between R to R intervals is going to change, right? So as you increase the variability, as you increase the distance, as you slow the heart rate down, you're going to be more in a parasympathetic tone. You're going to be more in a rest and recovery tone for your heart. So you're going to be more of a green light athlete. You're going to be ready to go sooner. If you flip it and we start adding sympathetic tone, what's going to happen to the distance between those R values? What's going to happen to the distance between QRS complex? It's going to decrease, right? So we're going to get a shorter time span between heartbeats, and the variability between those heartbeats is going to decrease. So as that heart rate variability decreases, our fatigue starts to go up, and that's when you kind of get athletes that are in a yellow or a red zone, right? Like they might not be able to train, or if they train, they feel like crap. That heart rate variability measure is a well-validated measure for measuring athlete burnout, athlete recovery, everything, right? So it is something that's worthwhile understanding parasympathetic and sympathetic tone if you're going into coaching. If you want to be a strength coach, this is a great way to know how to train your athletes, or how hard to push your athletes, I guess. So that's heart rate. How do we regulate stroke volume? Q equals HR times SV. We can't forget 50% of that equation, right? So stroke volume is largely going to be regulated by three factors. It's going to be our end diastolic volume, our EDV, which is how much blood is left after diastole. How much of that blood did we not pump? Average aortic blood pressure. How hard, like what's the blood pressure look like that we're trying to force ourselves against? How hard is it to beat or push that blood out, basically? And then how strong of a contraction do we get? How hard is the heart beating? What's the force with which the heart is beating? EDV, or end diastolic volume, is also known as preload. So what EDV is talking about is it's the amount of stretch. So essentially what preload and what EDV is talking about is as we increase the volume of blood that's in the ventricles prior to systole, prior to contraction, we're actually going to stretch those fibers out, right? We're actually going to stretch. Think of it like filling a balloon with water. The bigger the balloon, the bigger the pop. The bigger the balloon, the bigger the release of blood, right? Same thing is going on here. So what's happening is that we're actually stretching out those heart fibers. We're stretching out those small heart fibers. We're increasing the amount of actin and myosin cross bridges that can be combined because we're actually getting them into an optimal state. When that contraction goes to happen, we get more actin myosin cross bridges. That was me making cross bridges. I don't know why I was like drumming. And it's going to give us a stronger contraction. We're going to be able to push more blood out because we got a bigger stretch. So essentially what Frank Starling law is showing us and is telling us that the greater the stretch, the greater the contraction. Another major driver of stroke volume is going to be our venous return, right? So if we're not getting blood back from the closed circuit system in appreciable volumes, what do you think the odds are that we're going to be able to pump out a bunch of blood? Not very much, because there's a fixed amount of blood that's inside of our body, right? Unless we're infusing fluid into our body directly via IV, then that blood volume is fixed. So if we're not getting it back in high levels, we're not going to be pumping it out in high levels. Essentially, venous return is going to be driven by vasoconstriction. And what that means is that we're increasing pressures inside of the veins to drive blood back to the heart faster. Super complicated terms. Think about it as putting your thumb over the hose. I realize that most of you guys have probably never played in hose water because you grew up playing video games, but I'm sure you've at least put your thumb over the end of a hose or put your thumb over the end of a faucet, right? Like that is how you increase the speed at which that water is leaving the hose. Same thing is going on here with venous return. As we constrict those veins, as we constrict the venules, we're actually able to kind of force that blood to flow a little bit faster. Remember how I was showing you that the vascular system, certain vascular tissues are controlled by smooth muscle? They've got a muscle layer. That muscle layer that's going to constrict the venous return and constrict the veins is actually controlled by the sympathetic nervous system. So our fight or flight nervous system is actually going to be controlling our smooth muscle tissue diameter around our vasculature. The other thing is we're going to have a muscle pump, not like a great like bicep pump that you get from doing preacher curls or drop sets, right? Like unfortunately it's not that type of pump. It's how it works, but it's not that type of pump. Essentially, the rhythmic skeletal muscle contractions that are occurring as we're exercising, as we're moving, as we're living, are going to be actually compressing veins and actually pumping and forcing blood up against gravity back to return to our heart. Kind of neat, right? The reason that it doesn't go backwards is, one, we have the skeletal muscle pump pushing it back up. Two, we actually have backflow valves. So our veins are built with valves so that we don't get backflow through them. And it's kind of like, once it reaches through a valve, that valve clicks up and then closes, and then clicks up and then closes, right? So as blood's flowing through it, we're not allowing a backwards flow of blood to be occurring. The other thing that is going to control the venous return is going to be our respiratory pump. Just like we have this skeletal muscle pump, the respiratory pump is going to change pressures throughout the system by, as we breathe in and as we breathe out, we're going to be changing the thoracic and abdominal pressures based on how that air is filling our cavities. And it's going to drive blood back to return to the heart. Another major factor in stroke volume is going to be our aortic blood pressure. So what I want you to remember is think about the heart anatomy, right? We have a right atrium and a right ventricle. That right ventricle sends blood through the pulmonary artery to the lungs. The lungs are the site of primary oxygen and carbon dioxide exchange. We send that blood back to the heart via pulmonary veins. Pulmonary veins come into the left atria, and that left atria drains into the left ventricle. From that left ventricle, we're pumping blood up and out through the aorta to the body. Now, if we have a high aortic blood pressure, we're not going to be able to force a bunch of blood out of the left ventricle and out to the body. If we can't force a bunch of blood out, then we're not going to get a strong contraction. We're not going to get a bunch of blood flowing out throughout the system. So this concept of aortic blood pressure is really going to be one of the primary determinants of how hard our heart has to beat and what our stroke volume is actually going to be. This aortic blood pressure is actually going to be termed afterload. So we have a preload with end diastolic volume, and we have an afterload with aortic blood pressure. So afterload is going to be determining stroke volume. in large degrees. As afterload increases, stroke volume decreases. They're inversely related. So this is afterload, blood pressure in the aorta, the back pressure up against the heart, essentially. And then lastly, another key regulator of cardiac output is going to be catecholamines, right? The catecholamines and this fight or flight nervous systems and the sympathetic nervous system are going to be able to control the cardiac contractility, how likely the heart is to beat, how hard it is to pump, all that type of stuff is all controlled by epinephrine and norepinephrine levels. If we got to get away from the lion, I'm looking at a door. If we got to get away from a lion coming through the door, we need our heart to be able to beat hard and beat fast and provide blood to our body rapidly and at the level that it needs it. So it's going to increase the ability of the heart to actually contract, and that's catecholamines. So that kind of leads us all the way down to this summative figure here, this summative graph. And rather than work down to up, I want to work top to bottom. So cardiac output, Q or CO, is equal to heart rate times stroke volume. So cardiac output is equal to heart rate and stroke volume. As we increase heart rate, we increase cardiac output. As we increase stroke volume, we increase cardiac output, right? If we're going to increase sympathetic activity, we're going to increase heart rate because we know that the nervous system is directly innervating the heart. We have accelerator nerves that sit on the heart and are ready to speed up our heart rate. So if we increase sympathetic activity, we increase heart rate, we increase cardiac output. If we increase sympathetic activity, we also know that epinephrine and norepinephrine and the catecholamines are actually going to increase the contractility of the heart, the ability of the heart to beat harder and more forcefully. If we can increase the force of the heart, then we know that we can also increase the stroke volume of the heart because it's able to eject more blood out against the afterload, and it leads to increased cardiac output. If we increase sympathetic activity, we're also going to have venous constriction. We're going to have venoconstriction, and that's going to increase the venous return. If we increase the venous return, we fill the heart more, end diastolic volume, and if we have increased end diastolic volume, we get a greater Frank-Starling law. We get a better cardiac contraction because we have greater cross bridges. We have a greater stretch, so we have a greater contraction. We have a greater stroke volume. We have a greater cardiac output. Next video, we're going to be talking about kind of changes in blood flow, how changes in blood flow and how we affect blood flow can affect cardiac output. And we'll start talking about how cardiac output changes with exercise. So that's going to be under cardiovascular Phys video 2 or circulatory Phys video. I'm an idiot. Circulatory Phys video 3.